This is the recording for the Level 1 Pharmacology Workshop Exam Review. The first thing on our review is phenobarbital. It's a barbiturate. It takes longer to get out of the body. We have a high risk for toxicity, and this can lead to hypotension. Other things we're watching for is respiratory depression and sedation. Buspirone is also an analytic drug. With this drug, it's going to take 2 to 4 weeks to have full effect. There are no withdrawal symptoms, no sedation, and it's okay to drive on this medication because it doesn't cause the sedation. So drive the buspirone, like on the little sheet that we got in class. And we're not going to use for acute attacks, again, because this is going to take 2 to 4 weeks to have a full effect. So if we're doing patient teaching and the patient's like, I've been taking this drug for a whole week and it's still not working, as the nurse, you would tell the patient, okay, for the full effects of this drug, we may have to wait 2 to 4 weeks for it to work. Drug metabolism age considerations. So our age considerations with drug metabolism are going to be infants and the elderly. Infants, because we have premature or not quite developed kidneys and liver, and so they're not going to be able to metabolize and excrete drugs as quickly. And elderly, because with the elderly we have changes in the kidneys and liver due to aging, so they're not going to be able to metabolize or process drugs as quickly, and they're not going to be able to excrete them as quickly as like a young healthy adult. So they have the potential to have these toxic levels of drugs build up in their systems. Drug metabolism disease process considerations. Metabolic activity decreased in patients with renal and hepatic disease. So that's the same thing. So most of our drugs are metabolized in the liver. So if a person has hepatic disease, their drug metabolism is going to be slowed. So they're not going to metabolize these drugs as quickly. So the toxic levels can build up in their systems. With renal disease, they may not be able to excrete drugs as quickly. So again, that's just building up more drug in the system. So they can't metabolize it or excrete it as quickly with renal and hepatic disease. Protein binding. Plasma protein binding refers to the degree to which medications attach to proteins within the blood. A drug's efficacy may be affected by the degree to which it binds. The less bound the drug is, the more efficiently it can transverse cell membranes or diffuse. So with the drugs, if they're bound to a protein within the vascular system, it's bound to that protein and it can't reach its target tissues. If a drug is heavily protein bound and the dose was designed around normal protein within the blood, if somebody has low protein, less of that drug is bound to the protein, or so more is able to travel throughout the blood system and have like toxicity because it's not being bound to that protein. So let's say aspirin is a heavily protein bound drug. If you have an elderly person who who has like a low albumin, they don't have as much protein in their blood, they're going to have a greater risk for toxicity of that aspirin because less of it is bound to the protein in the blood and more of it is reaching target tissues. So you have those increased risk for bleeding and those other adverse effects. The importance of knowing all the supplements and drugs a client takes. Supplements can change drug absorption and metabolism. So let's expand on that a little bit. So I know in class we brought up the example of St. John's wort, and we can look at like Zoloft, a serotonin reuptake inhibitor. So Zoloft increases your serotonin levels in your blood, and St. John's wort also increases serotonin levels in your blood. That's how they both work. If you take them both together, you're going to have increased amounts of serotonin to the point where you might have serotonin syndrome, which can lead to seizures and death. You'll have a math question. So within your metric conversions, so we have 8 ounces in a cup and 30 mils in an ounce, so 1 times 8 times 30 is 240. CAM therapies, complementary and alternative therapies, natural plant extracts, herbs, vitamins, minerals, dietary supplements, physical therapy, manipulations, massage, acupuncture, hypnosis, and biofeedback. So all of our non-pharmacologic methods to treat any kind of ailment would be a CAM therapy. Like if somebody is doing like a sort of exercise or yoga or something for fibromyalgia and it works for them, that would be a CAM therapy. If somebody is using like a lavender essential oil in a diffuser to decrease anxiety, that's also a form of CAM therapy. Agonist, produce same response as endogenous chemical drug that is capable of binding with receptors to induce a cellular response. Antagonist, occupy receptor, prevent endogenous chemical from acting. So an agonist works to produce the same response. Antagonist is blocking the response. Physical dependence, an altered physical condition caused by the adaptation of the nervous system to repeated drug use. When the drug is no longer available, the individual expresses physical signs of discomfort known as withdrawal. So the drug has been used for such a period of time that the nervous system has adapted to that drug constantly being present. The example that we used in class was alcohol. So if somebody uses alcohol on a regular basis, repetitively, the body gets used to that CNS depressant, the alcohol, depressing the central nervous system. So the central nervous system is kind of pushing back to reach that homeostasis to be at a normal level. And when the alcohol is removed, you're going to have withdrawal symptoms such as elevated blood pressure, tachycardia, or elevated heart rate, anxiety, because that physical dependence happened because of the repetitive or the repeated use of the drug, and now the central nervous system has adapted to that drug constantly being present. Next one is physiological dependence. Physiological dependence. Few signs of physical discomfort. Psychological dependence. Few signs of physical discomfort when drug is withdrawn, but intense, compelling desire to continue using drug. Psychological dependence. So we're not having the physical withdrawal symptoms, but the person still has this compelling desire to use the drug. Controlled substance schedule. So we're looking at 1 being the highest potential for abuse, limited or no therapeutic use, heroin, LSD, marijuana, peyote, methamphetamines, and then ecstasy. So that's Schedule 1. Schedule 2 has a high potential for abuse and dependency. We have hydromorphone or Dilaudid, methadone, oxycodone, fentanyl, phenobarbital. Moderate potential for abuse or physical dependency. Combination products containing less than 15 milligrams of hydrocodone. And then lower potential, we have like our alloprazolam, clonazepam, diazepam, lorazepam, some of our analytic drugs. Lowest potential is going to be our cough preparations that don't contain more than 20 milligrams of codeine. So just remember, 1 is going to be our highest potential, and 5 is going to be our lowest. And then they'll go in between there, categorized based on their potential for abuse, but 1 being the highest and 5 being the lowest. Our new drug development timeline. So we have our preclinical investigation done in the lab, usually animals, plants, different types of things are tested. Clinical investigation, we have our clinical phase trials, clinical phase trials 2 and 3, and then our NDA review, And then after the drug is on the market, we're going to have post-marketing studies. And this is the drug's already on the market. This is where all nurses take part in it. The drug's already out in the market. It's been deemed safe, but you're still watching for any adverse effects as a practicing nurse. Why are new drugs so expensive? So the drug company has, from the beginning of their whole drug development, 17 years. So if this doesn't take, let's say, this whole process took 10 years, just they would have the drug for 7 years. And for that 7 years, they could charge what they saw suitable for that drug. So why are new drugs so expensive? Well, drug companies are trying to recoup the cost of all the years that it took them to produce the drug. Pregnancy categories. 5 categories of risk that a drug poses to a fetus in case of a pregnant woman taking the drug. So A, controlled studies in women fail to show risk to the fetus, and possibility of fetal harm appears unlikely. So on this scale, A is going to be the safest and X is going to be the worst. So A and B should be okay to take during pregnancy. So A was studies fail to show harm to the fetus. B, animal reproduction studies have not shown a fetal risk or adverse effect. Risks have not been confirmed in controlled studies in women. C, either studies in animals have revealed adverse effects on the fetus and there is no controlled study in women, or studies in women or animals are unavailable. D, there is confirmation of fetal risk, but the benefit from use in pregnant women may be acceptable despite the risk. Example, in a life-threatening situation for a serious illness, which safer drugs are not used. X, animal and human studies have shown fetal abnormalities. The drug is contraindicated for women who are or may become pregnant. So generic versus trade versus chemical names. Drug has one chemical name. It's often complicated, difficult to pronounce, difficult to remember. Look at the chemical name for diazepam. I'm just going to highlight it. I'm not going to attempt to go through all of that, but it's a long, complicated name. And there's only one chemical name for every drug. There's also only one generic name for every drug. It's assigned and adopted by the U.S. Adopted Name Council. It's less complicated and easier to remember, and it's lowercase. A drug has several trade names assigned by the company marketing the drug. It's short, it's easy to remember. It's also called a proprietary, a product, or a brand name. And then the drug developer has exclusive rights to name and market a new drug for 17 years. But after that 17 years from the beginning of the development of a drug, you'll see other companies that will make the drug. So like we have Benadryl, brand name. The generic name is diphenhydramine. But then you might have like Walmart make, I'm not sure what the Walmart name for the generic is, but it might be like Wall Dry or whatever it may be. And then you'll like see like Target or Walgreens and all the other companies make their own version of diphenhydramine. Prototype drug approach. A prototype drug serves as a model for a drug class. It is well understood, has a known action and adverse effects. It is used to compare other drugs in the same pharmacological class. May not be the most widely used drug in the class, and disagreements may exist to which drug should serve as the prototype drug. So a prototype drug, it's the one drug we're going to learn in the pharmacological class, and it's because it's well understood and its side effects are well understood. Pharmacodynamics. Pharmacodynamics, how a medicine changes the body. Helps to predict if a drug will produce change. Will ensure that drug will provide safe, effective treatment. Combination of drug guides and Intuitive experience will guide safe treatment. So what are we expecting this drug to do in the body? How is the drug going to change the body? Let's say somebody takes Lasix or furosemide. We predict that it's going to diurese the patient. We're going to predict that it's going to cause increased urination because it's diuresing the patient and they're losing fluid through urine. We're going to expect their blood pressure to drop. If they have edema on their feet and we're giving them this drug that's a diuretic, we're going to expect that edema to go down a little bit. Because they're losing fluid, we're going to expect their weight to go down. So that's just going back to pharmacodynamics. How is this medicine going to change the body? What kind of effect will this drug produce? Now let's look at pharmacokinetics. So ADME, A-D-M-E, ADME. So we have absorption. So from location and administration. So we have our sites. Our IV is going to be the fastest, and all of our sites that we use, like injections, like our IV, our IM, our sub-Q, we're going to bypass the first pass effect. So they are going to you're going to have more bioavailability. Our fastest is going to be our IV, second IM, and then sub-Q. Other sites of absorption we have like inhaled, sublingual, parectal, and oral. Distribution sent to specific areas via the bloodstream, mainly by the Distribution sent to specific areas via the bloodstream. Metabolism, mainly by the liver. Things to remember is that our PO medications are going to go through the liver, and some of the drug may be removed by the first pass effect. In certain drugs, a lot of the drug is metabolized by the liver, and a lot of the drug is removed and not available to reach target tissues. Lungs, kidneys, blood, intestines. For metabolism, metabolic activity may be decreased in some patients. We talked a little bit earlier. If we think about it, like the majority of our metabolism is going to occur in the liver. So infants and the elderly. Infants, their liver isn't fully developed. The elderly, we might have some age-related things going on with the liver where they're not going to be able to metabolize drugs as quickly. And then patients with severe liver disease, if the liver is diseased, it's also not going to be able to metabolize drugs as quickly. And then patients with certain genetic disorders. So if there's anything going on with the liver that may decrease the rate of metabolism, you have the potential for toxic levels of the drug to build up in the blood. Excretion. So excretion, we have renal, fecal, glandular, and pulmonary. First pass effect, the concentration of the drug is greatly reduced before it reaches systemic circulation. And first pass effect is occurring in the liver. So it's going through the liver, and the liver takes out some of the drug, and before it reaches systemic circulation, or before it gets to the bloodstream, a portion of the drug is removed. Pharmacotherapeutics, the application of drugs for disease treatment, alleviation of suffering. Therapeutic class. So therapeutic class, what therapy is it providing? Based on therapeutic usefulness in treating a particular disease or disorders. Examples, antidepressants. So this is therapeutic class. Antidepressants are going to treat depression. Antipsychotics will treat psychosis. Antineoplastics will treat cancer. So what kind of therapy are we trying to provide? What are we treating? Pharmacologic class addresses the drug's mechanism of action. How does the drug produce its effect in the body? So like a diuretic, it's going to diurese or cause that diuresis. So let's look at our therapeutic range. So we have administering the drug and it's going to come up and it's going to build up. And when it finally reaches therapeutic range, so here we have the minimum effective concentration and then the toxic. We want to be in this, I guess, like this little peach colored area, like between 6 and 12 for this particular table. So its duration of action is going to be once it reaches 6, and once it reaches its peak, we're here, and then when it starts to get down to the point where it's below the minimum concentration or minimum effective concentration level, that's just going to be our duration of action. So from when it reaches minimum effective concentration to where it leaves that. And we always want to be within this range. We never want to get into the toxic range. If we get into the toxic range, we are having like an increased possibility of the adverse side effects, but we're not getting a greater effect of what we're trying to achieve, of any of the good things going on with that drug. We're not being therapeutic anymore, but we are increasing the risk for toxic side effects. A loading dose is a larger than standard dose to help reach therapeutic range sooner. So let's say you have somebody on like an IV antibiotic. They might give them a larger dose initially just to get within this therapeutic range faster. And then the other doses will be just to maintain it within this range. Routes of administration, please refer to the PowerPoint. Like if I put something under my tongue, it's sublingual, and all of your routes of administration. Transdermal patches, we know those are absorbed through the skin. If I'm going to apply them, I'm going to wear gloves because there's the potential, if that medicine is going to absorb through their skin, if I get it on my skin, I can potentially absorb some of that medication also. Sustained release capsules. Sustained release tablets or capsules are designed to dissolve very slowly, created to increase compliance by reducing frequency of dosages. Topical applications, topical medications, applications, dermatologic preparations applied to the skin, most common. Installations and inhalations applied to body cavities or orifices. Inhalations applied to the respiratory tract by inhalers, nebulizers, or positive pressure breathing. PO medications. So PO medications. Before I give a PO medication, I'm going to assess that the patient is alert and has the ability to swallow. So you don't want to give a patient who is like falling asleep, barely conscious of PO medication because you don't want them to aspirate or choke. Place the tablet or capsules into a medication cup. If the medication is in liquid form, shake the bottle to mix the agent and measure the dose into the cup at eye level. Hand the patient the medication cup. Offer a glass of water to facilitate swallowing of the medication. And milk or juice may be offered if not contraindicated. With certain medications, you cannot take them like with grapefruit juice or other things. But you can offer milk or juice if it's not contraindicated per the specific medications that you're administering. Remain with the patient until all the medication is swallowed. So you don't want to leave the medicine cup and then walk out of the room because then you don't really know if the patient took that medication. So individual factors affecting drug absorption and metabolism. We have age. So we talked about infants or the elderly may have decreased metabolism. Weight, that can affect drug absorption, especially if you're giving like a subcutaneous or IM injection. Sex and disease can all affect absorption and metabolism of drugs. The 5 rights that we are using, and I just said it like that too, is because sometimes some books will go into further rights, but these are the 5 rights. Then from there, like they may add like 6 rights or 7 or 8. But for our purposes on this exam, this is what we are using. The 5 rights used as the basis for safe delivery of medications are right patient, right medication, right dose, right route of administration, and right time of delivery. G-tubes, gastronomy, G-tube is surgically placed directly into the patient's stomach. This is longer-term treatment. Generally uses liquid drugs or pills that can be crushed or mixed with water. And you want to make sure that you flush this tube after use because you don't want this tube to get clogged. Efficacy versus potency. Efficacy, magnitude of maximal response that can be produced from a particular drug form. Pharmacotherapeutic perspective, efficacy almost always more important than potency. Potency, the strength of a drug at a specific concentrated dose. Drug with a higher potency produces a therapeutic effect at a lower dose compared with drugs of the same class. So potent is how strong the drug is, effective or efficacy is how effective the drug is. So this is like the concentration of the drug, and this is how effective it is. So if I have a drug like at a lower potency that's more effective, I'm going to use the drug that's more effective. Efficacy is going to be more important than potency. Like somebody might be, well, let me try to think of an example. My loved one sprained their ankle. And let's say 800 of ibuprofen is working great to alleviate their pain, but they're like, oh, my loved one really is in pain, and can you please give them like, I don't know, 2 milligrams of morphine. We want to give whatever's going to be more effective versus what's going to be more potent. So potency is how strong something is, efficacy is how effective it is. Nursing intervention for allergic reaction. Allergic reaction is an acquired hyper response of the body defenses to foreign substance. If discovered, the nurse is responsible for labeling charts, informing all personnel, and placing an alert bracelet on the patient. So some kind of hyper response of the body. Like let's say you give somebody a medication and they land up having a rash. You as the nurse, you're going to have to label the patient's chart, let the doctor know, let the pharmacist know, and go put an allergy alert bracelet on the patient. And depending on what the provider tells you, that you may get orders to discontinue the drug. It just depends what they're getting the drug for and how severe the reaction is. Black box warning. One of the primary alerts for identifying extreme adverse drug effects discovered during and after the review process. So black box warning is a very adverse effect that could, or a very adverse side effect that could happen when taking this drug. One that you could think of, or one that may, that's common, that's easy to think of, would be like antidepressants, and may cause suicidal ideation in young adults. So that would be an example of a black box warning. That's everything on the review that I have for the exam. I would fill out this review. I would look at PowerPoints and any handouts that we received in class.